countries. So this is going to be very, very nice. Very experienced people are going to talk to you and how we can make great programs all around the world. And on next Wednesday, not this Wednesday, the next one on the 7th of July, we are going to have a very interactive classroom. Dr. Gupta and Dr. Aurelio are going to teach everybody how to do these 3D visualizations with a CT angio. So this is going to be very interesting. It's going to be very practical, and they are going to use softwares that are low cost, so everybody can use the technology that they are going to teach you how to use and to understand the images. I'm sure this is going to be very nice and very useful. On July the 12th, we have the last class of Dr. Silverman for this a part of the year. Then he is going to be on a break. We are going to have the second part of the functionally single ventricle. So this is going to be awesome. I hope all of you can join. And then after that, we have on the last Thursday of the month, the fetal cardiology series. And now this is going to be the last meeting with Dr. Anderson of this semester. And hopefully he's going to come back in September with us. And so I just was thinking about it and how great was all of this time with him. And I placed some things together just to remember how it was with all of you guys.
To everybody, this is Bob Anderson. I'm talking to you from London. To everybody.
So we started this with 4 meetings talking about the development of the heart. They were small meetings for 30, 40 people. And it was great. Everybody who attended said great things about it. And then we thought it would be a good idea to make these sessions with Dr. Anderson for a bigger audience. So exactly 1 year ago, we started with the first one for the big audience that was starting the ASD. And since then, we've done a lot of things. We got used to every Friday to have his great diagrams, and I've learned about the Carnegie stages of the heart development, and we learned how to see these developmental images of the fetus of the mouse and the human fetus as well. I've learned what is an episcopic image and much more. We got used to these amazing pictures of morphological specimens, all of them with labels, so it made us much easier to understand. In the beginning, it was me and Sasha and Dr. Anderson, but soon Dr. Silverman joined us as a panelist, always giving amazing opinions and talking, making even better these meetings to us. We had a few more clinical meetings as well. This was one of them. We have a few of them. It was very nice. It was one of my favorites because Dr. Anderson was talking about morphology, and then we placed what we learned on a practical approach. Then Dr. Diane Spicer joined us, showing live her specimens. That was something that added so much to this meeting. And now we have this great panelist that so made this discussion so rich. And so this session, this series became better and better over this 1 year. And with this, we were able to place together 54 webinars. And more than 16,000 people attended live on YouTube, Dr. Anderson webinars from more than 100 countries. And I'm sure all of them learned so much. I remember one of these webinars, Sasha said something that was very interesting. Dr. Anderson was explaining about D-loop and these things. And then he said, you know, Bob, we spent a lifetime trying to understand this, what you explained it so clearly in 5 minutes. And this is so true. We learned so much because he placed things together and explained such an easy way that all of us were able to learn a lot. And more than the 16,000 people that attended live and were able to make a lot of questions. Every webinar had at least a dozen questions. So it was great because everybody was able to participate and to solve their doubts. And we had almost 65,000 views on YouTube. So I'm sure this is a great legacy from Dr. Anderson. This is going to be there, and people can watch again and share with their teams, and people who are graduating, who are entering our field are going to be able to learn. So this is a great legacy, and thank you very much, Dr. Anderson. And what we want to ask you is that your book still has a lot of chapters, so please continue with us. Let's continue to do this great series on the next semester.
Well, good afternoon to you all, ladies and gentlemen. This is our final session for this season. And so what we're going to do today is we're going to discuss some very strange hearts in which the arterial trunks arise from their appropriate ventricles, but in inappropriate fashion. And I'm going to be joined today with several other of my collaborators, in addition to Diane, who will be showing you two of the hearts today. So this hopefully will be what we will be able to achieve next year, when I hope to share our experiences with several collaborators so that you can see the anatomy as you have been shown it for the past few weeks by Diane. So let's start today, and let's look at these unusual hearts in which the arterial trunks arise from their appropriate ventricles, but with unexpected infundibular morphologies, and most importantly, with unexpected relationships between the trunks as they extend into the mediastinum. Been stressing the need for a logical approach. So as you know, throughout our sessions, we've been stressing the need for a logical approach. And from the outset, we've discussed how it was the introduction of segmental analysis that produced the necessary logic. And from the outset, we've recognized the huge contributions made by Richard and Stella van Praag in introducing segmental analysis. So today we're going to discuss the analysis of the segments and try to produce a logical approach to those unusual arrangements in which the arterial trunks arise from the appropriate ventricles, but they do so in unexpected fashion. Now, to do that, we're going to have to go back to this diagram that was produced by Richard van Praag to show you the different ways in which the segments can be joined together. And it's difficult to take this in all at one go, but if you look down, you'll see that the primary feature on which Richard is concentrating as he produces these so-called segmental sets is the way that the arterial trunks are arising from the ventricles. Now, we've discussed several of these already, and we've shown that segmental analysis, our approach, sequential segmental analysis, did indeed simplify the situation. So we've discussed transposition. And I hope we've established that if you approach transposition on the basis of discordant ventricular arterial connections, then that removes all the controversies that bedeviled this situation throughout the years. We've discussed double outlet right ventricle, and we've agreed that no longer do you need bilateral infundibulums so as to make the diagnosis of double outlet right ventricle. All you need is to have both arterial trunks and their greater parts arising from the morphologically right ventricle. We have not discussed double outlet left ventricle in any great deal of emphasis, but what we have discussed is how the situation in which you have double outlet from both ventricles can lead eventually to that situation in which the arterial trunks in their greater part arise from the morphologically left ventricle. And we know that that is one of the rarest types of ventricular arterial connections. So today we're going to discuss the even rarer types. And if you go back to that list of segmental sets that was produced by Richard Van Praagh, you'll see that he's given these segmental sets very strange names. So one segmental set he calls isolated atrial discordance. We're going to look at that in just a moment. And we're going to compare it with another segmental set, which Richard calls isolated ventricular discordance. If you look at his table in great depth, you'll see that he shows one particular set that he calls isolated infundibuloventricular discordance. Now, can you have the situation in which the infundibulums are separated from the ventricles? In fact, what he is discussing here is unusual infundibular morphology. And we will come to that. But what we are going to concentrate upon is that set of hearts which Richard likes to call anatomically corrected malposition. Now, we have spent some time thinking about these in the past because previously this particular set was called anatomically corrected transposition. And this is the set we're going to concentrate upon during the remainder of today's discussions. But we're going to have to put it into the context of all these other sets. So as I say, let's come back for a moment and let's compare what's going on in these two sets, which Richard calls isolated atrial discordance, as opposed to isolated ventricular discordance. Now, it's difficult for you to appreciate what's going on when this is in the middles of such a complicated table. So I've blown it up here, and I'm sorry it's a little bit fuzzy, but this was the best I could do with the diagram I had at my disposal. And on the top now, you see the sets that Richard calls isolated atrioventricular discordance. And I'm going to compare that with the lower sets, which he calls isolated ventricular discordance, because in reality, there is not that much difference between them. Now, you're going to have to concentrate now, because these are very subtle points that we are discussing, but hopefully we'll be able to look at them in detail and clarify exactly what is going on. So let's start by looking at the top right-hand set. And there you see the key to this set, because that is the pulmonary trunk. It's shown to you in anterior and right-sided position. And that is what Richard calls inversus. It's the mirror image of the normal ventriculo-arterial relationships. And what you can see is that Richard has shown there an infundibulum that is spiraling around the aortic root, such that the pulmonary trunk is, as I say, anteriorly positioned and right-sided. If you look at the rest of the heart, you'll see that the atrial chambers are in their expected positions, situs solitus, and there is left-handed ventricular topology, so that the atrial chambers are connecting to morphologically inappropriate ventricles. The ventricles are then giving rise to appropriate arterial trunks. Let's now compare that to the subset directly beneath. Because here now again, you see the pulmonary trunk. It's arising from the morphologically right ventricle, but this time, Richard has labeled it as being solitus. and Solitus, of course, is the usual arrangement. But look for a moment at the upper right-hand panel, because there again is the pulmonary trunk, and this time the pulmonary trunk arising from the right ventricle, supported by an infundibulum, is spiraling around the aorta in normal fashion. And in fact, that is what Richard has labeled as Solitus, the usual arrangement. But in the upper right-hand panel, what you see is that Solitus arrangement is shown in the setting of right-handed ventricular topology. Whereas here in the lower left-hand panel, we have the arrangement that the pulmonary trunk is rising from the morphologically right ventricle, which itself is showing left-handed topology, but Richard is suggesting that this is Solitus or usual. And in fact, you can then look at the situation directly above that, where you see what is the usual arrangement for mirror-imaged ventricular arrangement or left-handed ventricular topology. So if we're going to sort all of this out and we're going to produce the necessary clarity, we have got to understand what are the normal ventriculo-arterial arrangements. And you see, I'm talking here about the overall arrangements, because the larger part of those normal arrangements is, of course, concordant ventricular-arterial connections. But in the normal situation, the usual situation, which we see with right-handed ventricular topology, the arterial trunks are spiraling, but the pulmonary trunk spirals around the aorta, which is located posteriorly and right-sided, so that as the pulmonary trunk leaves the base of the heart, it does so from an anterior and left-sided position. This is one of the paradoxes of the usual arrangement of the heart, despite the fact that the aortic trunk arises from the left ventricle, it does so in right-sided and posterior position. And of course, you're all well aware that in the normal heart, it is the presence of the muscular subpulmonary infundibular sleeve that lifts the pulmonary valve away from the base of the heart, permitting it to spiral in that fashion round the aortic trunk as it extends into the mediastinum. That right-sided aortic root is in fibrous continuity with the left-sided mitral valve. So to put all of this into context, Diane is now going to show you the normal ventriculo-arterial arrangements in the usual situation, showing you the connections, the relationships of the arterial trunks, and the infundibular morphology.
Here we're looking at a normal heart in anatomic position, so the diaphragm would be on this inferior aspect. If I fold back the right atrial appendage, we can see the normal spiraling of the arterial trunks as they leave the ventricular mass, so that the aortic root is rightward and posterior relative to the pulmonary trunk. Now, if we look at a dissected specimen where I've removed the free wall of the right atrium and right ventricle and the pulmonary trunk, we can clearly see the rightward and posterior position of the aortic root relative to the pulmonary trunk. This is a normal heart, so that it exhibits right-hand ventricular topology, where only the palm of my right hand can be placed on the septal surface with my thumb in the inlet and my fingers in the outlet. If we look at a short axis apical view of a normal heart, this shows us nicely the rightward and posterior position of the aortic root relative to the pulmonary trunk. Also, the rightward aortic valve is in fibrous continuity with the left-sided mitral valve. This view shows us nicely how the spiraling of the subpulmonary infundibular sleeve underscores the spiraling arrangement of the arterial trunks as they extend into the mediastinum. So you can clearly see that subpulmonary infundibular sleeve wrapping around the aortic root, which is the centerpiece of the heart. Looking at this from the base, we can see nicely that subpulmonary infundibulum spiraling anterior to the right-sided, posteriorly located aortic root. Looking at the normal heart, once again, we see the spiraling of the subpulmonary infundibulum, underscoring the spiraling arrangement of the arterial trunks as they extend into the mediastinum, so that the aortic root is extending from posterior and towards the right, and the pulmonary trunk and the subpulmonary infundibulum are extending anterior to the aortic root and towards the left. So effectively showing us the nice spiraling of our arterial trunks as they extend into the mediastinum.
So now you understand the usual arrangement, situs solitus, if you will. Let's now turn our attention to what is the mirror imaged arrangement. And remember, we have again to consider this in terms of those three features: connections of the arterial trunks to the ventricular mass, relationships of the arterial roots, and the infundibular morphology. So when we look at the usual mirror imaged arrangement, we're going to find it in the setting of left-handed ventricular topology. So this is what you would see in the mirror imaged normal heart. And in that setting, there would, of course, be concordant ventricular arterial connections. Again, the arterial trunks would be spiraling as they leave the base of the heart, but this time, the aortic root is going to be posterior and to the left, because it needs to be the mirror image of the normal arrangement. But again, there will be a subpulmonary infundibulum. The subpulmonary infundibulum will lift that pulmonary valve away from the base of the heart. This time, it will spiral from left to right as the pulmonary trunk ascends into the mediastinum. And this time, the left-sided aortic root will be in fibrous continuity with the right-sided mitral valve, because, of course, morphologically left ventricle in the setting left-handed ventricular topology is going to be right-sided. So this is the arrangement that Diane is going to show you now. We don't have a mirror-imaged normal heart to show you. So what Diane is going to show you is this arrangement in the setting of a heart that has left isomerism of the atrial appendages, but which does have left-handed ventricular topology, with the ventricles giving rise to their appropriate arterial trunks. And she's going to emphasize the spiraling of those arterial trunks as they leave the base of the ventricular mass.
We've seen this small specimen in several of our webinars thus far, and we know that there is isomerism of the left atrial appendages, so that the atrioventricular connections are biventricular and mixed. There are concordant ventriculo-arterial connections in this specimen that are spiraling in mirror-imaged fashion, so that the aorta is now leftward and posterior relative to the pulmonary trunk. If we look inside of the left-sided morphologically right ventricle, we can see that it exhibits left-hand ventricular topology. Only the palm of my left hand can be placed on the septum with my thumb in the inlet and my fingers in the outlet. So here we have the subpulmonary muscular infundibulum, or the infundibular sleeve, and it is spiraling anterior to the leftward and posterior aortic root. It gives rise to the pulmonary trunk. When we look at the left ventricle, or the morphologically left ventricle on the right side, it is the hypoplastic of the two ventricles in this specimen with an unbalanced common atrioventricular junction, so that the aortic outlet is extremely stenotic. If I spread my forceps, we can see the aortic root spiraling out from behind the pulmonary trunk and extending leftward. So there's the pulmonary trunk, and my forceps are in the aortic root. It's also worth mentioning that the left-sided aortic valve is in fibrous continuity with the right-sided component of the common atrioventricular valve. So that now we have mirror imaged spiraling of the arterial trunks with the aortic root arising leftward and posterior to the pulmonary trunk.
So we now need to look at these normal arrangements, which you've now seen in the setting of the normal heart, in the setting of left-handed ventricular topology. And we're going to have to consider that in the feature that unifies all those other arrangements we've been discussing thus far in the setting of Richard's segmental sets. And the thing that links them all together is the concordant arrangement of the ventricular arterial connections. In other words, the arterial trunks are arising from their appropriate ventricles. So the question we now have to ask is, how do they vary not only in the normal situation, but also the mirror imaged variant of normal? And what we are going to show you is that they vary in terms of the relationships between the arterial trunks and the fact that the infundibular morphologies are other than what we expect them to be. So to clarify the situation, we've got to come back to the basic arrangement of the ventricular arterial junctions. And when we consider their features, as I've said, most important is the way in which the arterial trunks arise from the ventricular mass. And as you know, that is what we call the ventricular arterial connections. The second feature is infundibular morphology. And the third feature is the pattern of the arterial trunks, that their relationships as they extend into the mediastinum. And we have two situations to take into account here. One is the relationships of the arterial roots to themselves, and the other is the nature of the trunks as they extend into the mediastinum. The most important thing is that these features, connections, relations, infundibular morphology, are independent one of the other. And this takes us back to the principle that has governed assessment of cardiac morphology throughout all of our sessions, the so-called morphological method. I would remind you again, this was introduced by Richard Van Praagh. He was criticizing one of our manuscripts a long time ago now, but he was 100% correct. We should not use one feature that is itself variable to define another variable feature. And this is particularly important in today's discussions, what it means. We should not use relationships or infundibular morphology to put a specific name on a given heart. So, if we are to account for these hearts that have in common the same ventricular arterial connections as we find in a normal heart, we need to look how they differ. And in fact, the different feature is that as the arterial trunks extend into the mediastinum, they do so in parallel rather than spiraling fashion. So how do we analyze these hearts? We do so by using sequential segmental analysis. So we start by establishing the arrangement of the atrial appendages. Then we look at how the atrial chambers join to the ventricles across the atrioventricular junctions. In other words, we determine atrioventricular connections. We know that there are going to be concordant ventricular arterial connections. The arterial trunks are going to arise from their appropriate ventricles, so we need to find out what is unusual in this setting. So we need to look at the infundibular morphology, and then we need to account for all the associated malformations. And now we have a very nice heart to show you that illustrates all of these points, and it's going to be demonstrated to you by another very good friend and colleague of mine. She's also a very good friend and colleague of the chairperson of the Congenital Heart Academy, and it's Professor Vera Aiello from Incor in Sao Paulo, and Vera is now going to show you a very nice example of hearts, of a heart that has concordant ventricular arterial connections, but with parallel rather than spiraling arterial trunks.
This heart specimen belongs to a 38-year-old woman who died in the immediate post-operative period due to coagulopathy. She was directed to surgery to close a big VSD, and the original diagnosis was double outlet right ventricle with subpulmonary stenosis. We can appreciate externally that both great vessels rise here, the aorta to the left and anterior to a huge pulmonary trunk. You can see here, huge pulmonary trunk. And one thing that calls our attention is that both great arteries run in parallel and not spiraling as usual in the normal heart. Also, on the external surface, we see on the left margin of the heart, the juxtaposition of the atrial appendage. Here's the morphological right atrial appendage. Here's the left atrial appendage, both juxtaposed on the left side of the heart. We also can see that the aortic arch runs to the left, the first branch being the brachiocephalic artery, the right carotid, and the right subclavian artery. The venous connections to the atriums is normal. The superior cable vein, the inferior cable vein, both coming to the morphologically right atrium. We can see here the trabeculated appendage reaching the diaphragmatic surface of the heart. At the septal surface, we see some surgical stitches here, probably closure of interatrial communication or ovoforamen patent, and also the entrance to the juxtaposed atrial appendage at the left side. We are now observing the right AV valve, the tricuspid valve, that also has been some corrected here with some surgical stitches. I'm going to zoom the image so we can appreciate better. We see that the right AV valve, the tricuspid valve, overrides the top of the ventricular septum here, and the degree of overriding is approximately 40% towards the left ventricle there. We can see the right ventricle here, the somewhat hypoplastic trabecular portion. At the outlet, we see here a complete muscular infundibulum. There was kind of resection here because clinically there was some pulmonary stenosis, and the pulmonary valve is dysplastic, thickened, but it was not surgically approached. See this right ventricle that is small, I would say. Turning to the left, we see the pulmonary veins reaching the left atrium, which has a smooth endocardial surface. This left atrium opens into the morphologically left ventricle via a mitral valve, very typical mitral valve with some degree of thickening at the border, but the very thin and delicate cords. Looking carefully at the left-sided ventricle, we can see a smooth septal surface and apical trabeculations. So it's no doubt that this is a morphologically left ventricle. These cords you see here, these attachments are from the tricuspid valve that came from the right and inserts into a group of anomalous papillary muscle situated at the anterior wall of the morphologically left ventricle. At the outlet of this ventricle, we observe the aorta supported by a completed muscular infundibulum with some hemorrhage here. This infundibulum separates the aortic valve from the AV valves, from the mitral valve and from the overriding tricuspid valve. Let's take a look at the aortic valve. It's also thickened, but not as severe as the pulmonary valve. And we can appreciate there is only one coronary ostium, and this ostium bifurcates very soon into a right and a left coronary arteries. So, but the ostium is a single one and arises from a sinus that is adjacent to the pulmonary trunk here. So this is a situation where there is concordant AV. There are concordant AV connections, right atrium, right ventricle, left atrium, left ventricle, and concordant ventricular arterial connections, right ventricle, pulmonary trunk, left ventricle, aorta, with parallel great arteries and aorta to the left side of the pulmonary trunk. I would comment also that there are some features in this heart that are similar to the features described in the series published in 2007 by Dr. Ciscar Cavalli Garrido while she was in Toronto. And these features are the juxtaposition of the atrial appendages that was present in half of her cases. Also the anterior aorta that was also present in more than half of her cases, anterior and to the left, and some degree of overriding of the valve. Just to remind you that in this case of overriding tricuspid valve, we would expect the AV node to be present at the point where the ventricular septum reaches the junction, the atrioventricular junction. So the AV node would be situated here. And this area would be at risk in case of the closure of a VST. Okay, I took out the patches and some of the stitches to facilitate the observation of this specimen.
So now you've seen the heart that many of you might call anatomically corrected malposition. We prefer to describe it as having concordant ventricular arterial connections with parallel trunks. The example that you've seen had concordant atrioventricular connections. So because the connections are concordant, both the atrial, atrioventricular, and ventricular arterial junctions, the blood is going to go the right way round. But the problem is going to be with the associated malformations. And in this setting, the surgeon will correct those associated malformations. And because there are concordant atrioventricular connections, the surgeon will expect the atrioventricular conduction axis to be where it usually is. And so the rules that we have for ventricular septal defect, if that is one of the associated malformations, will be as we expect them from the usual heart. But on occasion, we can have the same situation, concordant ventricular arterial connections, parallel arterial trunks, but in the setting of discordant rather than concordant atrioventricular connections. Now, as you all know, usually when we have discordant atrioventricular connections, we have congenitally corrected transposition. If the same thing goes in which the arterial trunks are arranged in concordant fashion, so that the right ventricle is supporting the pulmonary trunk, the left ventricle is supporting the aorta, the atrial chambers connected to inappropriate ventricles, we have a strange situation where we have concordant ventricular arterial connections, but with the blood going the wrong way round. And to illustrate this, I'm very pleased that we're going to be joined by another old friend of mine. I first met Rohit Lumba when he was a fellow in Wisconsin. And Rohit has worked very hard. He's worked closely with me. He's now an attending pediatric cardiologist at Advocate Children's Hospital in Chicago. But he's going to illustrate to you a heart that comes from the Idris archive at the Lurie Children's Hospital in Chicago. And we're grateful for Raed Abdullah for making this heart available for us today. So now Rohit is going to show you this fascinating case of discordant atrioventricular connections, concordant ventricular arterial connections, but with parallel arterial trunks.
We're here at the Idris Archive at the Lurie Children's Hospital in Chicago, Illinois. We'll be reviewing a specimen which is originally categorized as being that of congenitally corrected transposition. Here we have the specimen laying in as attitudinally appropriate fashion as we can get it. We'll first take a look and evaluate the external features of this heart. You can appreciate a superior caval vein that enters a right-sided atrium. Here we have a right atrial appendage. If we turn our attention to the great vessels, we see that there are, in fact, two great vessels. We have an outflow tract here, and we have one here. It appears that the anterior outflow tract is an aortic outflow tract, whereas the more posterior is, in fact, the pulmonary trunk with branch pulmonary arteries arising from it, and that the aorta and the pulmonary trunk are actually in a parallel fashion rather than a spiraling relationship to one another. If we turn our attention to the posterior aspect of the heart, we can appreciate a left atrial appendage. With that, we'll place the heart back into attitudinally appropriate fashion with the anterior surface facing us. And we'll turn our attention to now the right-sided atrium as we begin reviewing the intracardiac findings of this heart. Upon opening this heart, we do appreciate that there are pectinate muscles that spill outside of the appendage of this atrium and extend all the way into the atrioventricular junction, making this right-sided atrium morphologically right in nature as well. We can appreciate that the superior caval vein is in fact draining into this morphologically right-sided right atrium, and that there is remnants of the inferior caval vein, which also was draining into this right-sided atrium. We can also appreciate that there is an intra-atrial communication, and can also appreciate the coronary sinus draining into this right-sided, morphologically right atrium. Now we turn our attention to the right-sided atrioventricular valve. And we can note that this right-sided atrioventricular valve, in fact, has two leaflets, and in fact has no connections to the septum. So once again, we've got a right-sided atrioventricular valve that has, in fact, two leaflets and no septal connections, making this consistent with a morphologically mitral valve. So here we have a right-sided morphologically mitral valve. If we turn our attention now to the ventricle itself, you can see that this ventricle is smooth-walled, does have some fine trabeculations towards the apical portion, consistent with a morphologic left ventricle. We also don't appreciate any septomarginal trabeculations or moderator band. As we further investigate this ventricle, we find that there in fact is an intraventricular communication, which seems to be consistent with a muscular ventricular septal defect. As we move beyond the muscular ventricular septal defect that we've appreciated, we come to our first outflow tract from this right-sided morphologically left ventricle. This valve here is in fact tri-leaflet. As we investigate this valve leaflet more in this outflow tract, we do see that there are coronary arteries from the epicardial surface that seem to arise from the sinus of this outflow tract. And upon closer inspection, we can find that in fact there is a coronary ostium here. And we can follow this back with our probe. And that in fact there is another coronary artery that arises from an adjacent sinus right here. And we've also demonstrated that from its epicardial course here. So in fact, we have now a posterior aorta arising from a morphologically left ventricle that is now no longer in spiraling orientation to the pulmonary trunk. Also, when we further investigate the relationship between this aortic valve and the mitral valve, we do notice that there is a separating area of tissue or an infundibular muscle that divides these two, providing mitral aortic discontinuity. If we now turn our attention to the left-sided atrium, we can note that the left-sided atrium has a very smooth-walled vestibule, consistent with a morphologically left atrium. We do note that there is a atrial appendage here, and that the pectinate muscles of this atrial appendage are in fact confined within the realms of this atrial appendage and do not extend to the extent of the atrioventricular junction, making this further consistent with a left-sided morphologically left atrium. Now, as we turn our attention to the left-sided AV valve, we do notice a dysplastic tri-leaflet valve here, which in fact does have septal connections, consistent with a tricuspid valve. So we have a left-sided morphologically tricuspid valve. You can appreciate that, in fact, there is some abnormal rotation of this valve apparatus, as well as some displacement of this valve itself. When we actually turn our attention to the ventricle itself, we see that this ventricle is more coarsely trabeculated. There are septal connections from the tricuspid valve to the septum of this ventricle. And we do appreciate the moderator band here as well, extending. And so, in fact, we do now have a morphologically right ventricle here. If we turn our attention to the outflow of this morphologically right atrium, we come to a tri-leaflet valve, in which none of its sinuses give rise to any of the coronary arteries, which we have found their origins previously. And we do see that this vessel, this pulmonary trunk, does branch into right and left branch pulmonary arteries. Thus, we have a pulmonary valve and subsequently the pulmonary trunk. It's important to note that this pulmonary trunk, in fact, sits posterior and leftward when compared to the aorta. Also of note, we can appreciate the ventricular septal defect from the left-sided morphologically right ventricle, and we can see the VSD living right here. So we'll place the heart back into attitudinally appropriate fashion. And just to summarize, what we found in this heart is that we in fact have a usual arrangement of the atria. We have discordant atrioventricular connections with concordant ventriculo-arterial connections. We do have both an intraatrial and an intraventricular communication. And we find that the aorta and the pulmonary trunk are abnormally related, with an aorta that is in fact anterior and rightward. And thus that is an overview of this specimen.
So now you've seen a very nice example where, when we have discordant atrioventricular connections, but concordant ventricular arterial connections, the blood is going to go the wrong way round, because the combination is not going to congenitally correct the circulation, despite the fact we have discordant atrioventricular connections. The good news here is that the surgeon is going to be able to restore the morphologically left ventricle to its systemic role simply by performing an atrial redirection procedure. And this is what happens when this is found in most instances, and that will be part of correcting any associated malformations. But of course, now the surgeon needs to take into account that the conduction system is going to be in an unusual position because of the discordant atrioventricular connections. So knowing that, the surgeon will be able to go in and hopefully correct the associated malformations without producing atrioventricular dissociation. But we've now seen concordant ventricular arterial connections with parallel arterial trunks in the setting of usual atrial arrangement, with concordant atrioventricular connections in the setting of usual atrial arrangement with discordant atrioventricular connections. We can have the same thing with mirror-imaged atrial arrangements, again with either concordant or discordant atrioventricular connections. But not all the hearts have these arrangements, because in fact, the finding of concordant ventricular arterial connections with parallel arterial trunks is quite common when we have isomeric atrial arrangements, and in particular, left isomerism. So we need to take that into account when we're discussing these segmental sets. We also know we can have it in the setting of tricuspid atresia, absence of the right atrioventricular connection. And we can also find it in the setting of double inlet left ventricle. Now, this is a particularly interesting set of combinations because usually when we have double inlet left ventricle with concordant ventricular arterial connections, it is what we call the Holmes heart. And this is a very nice picture of what you see in the so-called Holmes heart. There you see the incomplete right ventricle. It's sitting on the right shoulder of the ventricular mass. It's in anterior and right-sided position, and it is giving rise to the pulmonary trunk. But as the pulmonary trunk leaves the base of the heart and extends up into the mediastinum, it's doing what we expect it to do with the typical, usual arrangement of the ventricular arterial junctions. It is spiraling around the aorta and running from that right-sided incomplete right ventricle to a left-sided position of the pulmonary root, and then spiraling up into the mediastinum. And this is the typical Holmes heart, double inlet left ventricle with concordant ventricular arterial connections. But sometimes in the setting of double inlet left ventricle, as you see here, again, you can have concordant ventricular arterial connections. But what you're looking at here, the pulmonary trunk is arising from the left-sided incomplete right ventricle. Now we can make the inference here that the ventricular mass is showing us left-handed ventricular topology. And you know that probably in the commonest example of double inlet ventricle, we have discordant ventricular arterial connections, and then the aortic root is arising anteriorly and left-sided. This time, however, because we have concordant ventricular arterial connections, it is the pulmonary trunk that is arising in anterior and left-sided position. But as it's arising from the incomplete right ventricle, we still have concordant ventricular arterial connections. And as we have been discussing the other hearts we'll be looking at today, as the arterial trunks arise and extend into the mediastinum, they do so in parallel fashion. So here we have another example of concordant ventricular arterial connections with parallel arterial trunks in the setting, this time, of double inlet left ventricle. If we carry out full sequential segmental analysis, there is no problem in determining exactly what is going on. So you've seen various examples now of these hearts that have in common a combination of concordant ventricular arterial connections with parallel arterial trunks. Now, throughout the sessions during this season, I've been trying to provide for you logical explanations for the morphogenesis. So can we account for this strange arrangement? For quite some time, it was considered an embryological impossibility. But it can't be an impossibility because now you've seen several examples. So there has to be some way of explaining what's going on. And I believe we can now explain that on the basis of what I'm going to call abnormal plugging in. Now that's not going to mean much to you at the moment, so let me try to explain to you what I mean. If we go back just a step and think of the development of transposition, discordant ventricular arterial connections, we know now that that is the consequence of having a straight arrangement of the cushions that divide the outflow tract rather than the spiraling arrangement that produces the normal situation. So to produce parallel arterial trunks that are concordantly connected, what we need to do is to arrange the connections between the vessels arising from the aortic sac to those outflow tracts in opposite fashion. And I believe that can take place. So let's go back for a moment and let's look at the usual way in which the outflow tract separates itself so as to produce concordant ventricular arterial connections with spiraling arterial trunks. And what I'm showing you here is the outflow tract of a mouse heart at the situation in which the outflow tract, there you see it, remains supported by the right ventricle. And what you can see here in the middle part, proximal part of the outflow tract, is those cushions that are going to divide it into the systemic and the pulmonary channels. And in this wild-type mouse, these cushions are spiraling. And they're more distally, the outflow tract has separated itself into the pulmonary trunk, the intrapericardial aorta. The spiraling arrangement of the cushions themselves, the normal heart, is such that when the aortic root is connected into the left ventricle, it will take systemic blood, whereas the pulmonary trunk will retain its connection to the morphologically right ventricle and will receive the systemic venous return. Now here is a heart that is going to develop with discordant ventricular arterial connections. We know that it's a mouse in which we've knocked out PITX2. This is the gene which is responsible for reducing morphological leftness. We know that in mice in which we knock out PITX2, they develop what we might call the Towson Malformation. So here in this knockout mouse, again, you see the outflow tract. Again, you see it is supported by the morphologically right ventricle. But when we look now in the proximal part of the outflow tract, we see those cushions are no longer arranged in spiraling fashion. Instead, they are parallel one to the other. And there you see the arterial trunks, which are also parallel. And we know in this situation, it is the pulmonary trunk which will be transferred into the left ventricle. And that will give us the discordant ventricular arterial connections. And the major problem is the parallel rather than the spiraling nature of those cushions that are dividing the outflow tract. So what is going on within the aortic sac? Well, this is a picture of the aortic sac in the normal developing human heart. It's a dissection that was made by Szabolcs Virag, the outstanding embryologist who worked in Budapest. He collaborated with my colleagues in Amsterdam, produced this exquisite dissection that is shown to you by a scanning electron micrograph. And there you see the distal outflow tract, and there at the margins of the pericardial cavity, it is giving rise to the aortic sac. And arising from the aortic sac cranially, we have the systemic arterial channels. They are going to supply the fourth arch arteries. Arising caudally, we have the arteries that will feed the pulmonary circulation, and those are what we now call the pulmonary arches. And we've explained previously that what separates them is growth from the dorsal wall of the aortic sac of the protrusion, which we call the aortopulmonary septum. And that grows usually in such a way those systemic arterial channels are put into continuity with the developing aortic outflow tract. The pulmonary channels remain in continuity with the pulmonary outflow tract. But if they grow, if that septum grows in the opposite direction, it can reverse the situation. So the systemic channels connect to what would be pulmonary channel, but if we then have the similar discordance within the outflow tract, that will put systemic arterial channels back into the left ventricle, but in parallel rather than in spiraling fashion. So that is what I mean by plugging in. It is the way that aortopulmonary septum fuses with the outflow tract cushions, and then whether we have a parallel or a systemic arrangement will depend upon whether those outflow cushions themselves are parallel or spiraling. So I do believe we can now provide you with a good explanation of all these lesions. And what we have shown you today is how we produce concordant ventricular arterial connections with parallel arterial trunks. And that has been the feature that has combined the various entities we have been discussing. We also know from our knowledge of development now that the infundibular morphology will vary according to what happens to the inner heart curvature. And we also know, I hope as you've seen, that all these arrangements can readily be described using simple sequential segmental analysis. So what have we been trying to do? We've been trying to make things easier to understand. And I hope you'll appreciate now this is best achieved by description rather than codification, particularly for such complex arrangements. And we don't need those arcane terminologies anymore. We can make things simple to understand by simple description. So as you know, throughout our sessions, we've been stressing the need for a logical.
Sasha is much better than me doing the playing of the video. Okay, amazing. Okay, so we are good now. So Adrian has some specimens to show us, and then we can move forward to the discussion. Okay.
Hello?
Yes.
Would you like me to show the specimens now or a bit later after we have the initial discussion?
Oh, I think you should show them now and emphasize the points that we've made thus far.
Okay, so I'll start with this specimen. If there is a heart and lung block, so the heart is here, I'm looking from the top, and now I'm rotating the heart in an attitudinally correct position. You can immediately see the ventricular mass here. This will be the right atrium, and this will be the left atrium. And as you can anticipate from their external shape, and when we look inside of the extent of the pectinate muscle on the right and on the left, we can understand that this is a usual atrial arrangement. Now, if we go and look at the right morphologic right atrium, we will see that this is connected to an atrioventricular valve with the ventricular mass underneath. If I turn the heart and I look in the left atrium, this is also connected through an atrioventricular valve with the ventricular cavity. Now, this is a single ventricular cavity that connects the two atriums. And by morphology, it looks like crisscross trabeculations. Most likely, if I look also here, it will be a morphologic left ventricle. I'm turning the heart again anteriorly. And when we look at the great arterial trunks, we can see that on the right side is the aorta, and on the left side is the pulmonary trunk. It's left side and a little bit more anterior. And if I open this large ventricular mass that connects to both atriums, so for all intended purposes, it will be a double inlet left ventricle, we can see that the aorta comes off this large ventricular mass from the left ventricle, and the pulmonary trunk that comes in a parallel fashion with the aorta, here being the aorta, here being the reconstructed pulmonary trunk. I'll explain the surgery that was done. The pulmonary trunk comes from an anterior, superior, leftward small ventricle that is here. This is the small ventricle that you can see here, and this is a rudimentary right ventricle. But again, the connection between this right ventricle and the arterial trunk, it's a concordant one. The same likewise for the large ventricular mass, which is a morphologic left ventricle, and the aorta. So there is a double inlet left ventricle with concordant ventricular arterial connection and parallel arterial trunks. Now, the operation that was done here was just to reconstruct the pulmonary artery because initially it was hypoplastic. And I look back at the PM reports, and they described parallel arterial trunks in this double inlet type of ventricle even at that time, and it was in 1950, I think, that this heart was operated. So this is the example that Professor Anderson just mentioned about the rare Holmes heart, but with the right ventricle located anterior and leftward, which puts the pulmonary trunk where you would have expected the aorta. Any comments on this heart before I move forward?
That is absolutely beautiful, Adrian. It shows superbly that point, the heart that I showed using pictures. I think you've demonstrated that in spectacular fashion, and you've made all the appropriate points.
And thank you. Moving forward to this heart, this is a bit similar to what Rohit beautifully showed before. It's a 2-year, 4 months patient, old patient. The only operation that was done here was a classical BT shunt. This is the aorta, and this is the turn down of the right subclavian artery that goes into the right pulmonary artery. But explaining a bit more, I'm looking at in attitudinally correct position. This will be the morphologic right atrium. The morphologic left atrium is located here. So usual atrial arrangement. And if I open the right atrium, it connects with this kind of ventricular cavity. I don't have to mention that this is a morphologic left ventricle. It's crisscross, finely trabeculated. And if I look on the other side, on the left side, that the ventricle located on the left side of the septum, it has coarse trabeculations. Of course, even when I looked at the atrioventricular valve, I can see that on the right side, it's a morphologic left mitral valve because it has no attachments to the septum. And you can see the septum here that is free of atrioventricular valvular attachments. So for all intended purposes, this is discordant atrioventricular connection. On the left side, if I can show the valve, this valve has attachments to the septum. So it is a tricuspid valve. So for now, discordant atrioventricular connection. Let's look how these ventricles connect with their great arterial trunks. And you can see here that the aorta is located anterior and to the right, and the pulmonary trunk is parallel, located more to the left. There is a clear subaortic infundibulum, and there is also a subpulmonary infundibulum here. This is the pulmonary valve, and the atrioventricular valve is far below. Now, you can notice here that there is perimembranous outlet ventricular, interventricular communication, because there is continuity here on the posterior inferior border between the atrioventricular valves, but discontinuity towards the aorta. And just to complete, this ventricular intercommunication has its outlet septum deviated caudally, and it's just below the pulmonary trunk, producing subpulmonary stenosis. Hence, that's why a BT shunt was performed in this operation. So looking at the PM, it was described as a sort of anatomically corrected but not functionally corrected transposition, looking back at long ago. So again, discordant atrioventricular connections, concordant ventricular arterial connections, perimembranous outlet ventricular communication, interventricular communication with deviated outlet septum, parallel great arterial trunks.
And again, Adrian, a beautiful demonstration. I should say that in Rohit's presentation, sadly, I had not noticed that the images were turned through 90 degrees counterclockwise. So you had to be smart to appreciate what was going on in Rohit's presentation. But your presentation, again, is quite beautiful and shows exquisitely exactly what we're talking about. I think you have one more case to show us, do you not?
I have three more cases, one with left atrial appendage isomerism, one with tricuspid atresia. All the cases that you said are very rare. Fortunately, they are in our archive.
Goodness me, I did not realize we had quite so many. So
I can
stop doing very well. Show us the other ones.
Okay. So if we look at this one, this is another interesting specimen. Attitudinally correct position, you can look at the ventricular mass, but where is the appendage that should be here on the right side? We can see some sort of appendage here, but the appendages, I'm rotating the heart. And from the back, I'm looking at the back of the heart. This is the left side of the heart. Here they are, two appendages, and they are morphologically left. I looked inside. So this is the left juxtaposition of the appendages, and they are both of left morphology. So it's a left atrial isomerism in this case. This probe comes through a left superior caval vein that goes into a coronary sinus. This is the opening. So this is the morphologic left appendage that is on the left, and this is the migrated one. It's superior to, let's say, the native one. And if I open it, I can see all the pulmonary veins coming here. You can see how they connect from this left lung. And the operation that this patient had was closure of the atrial septal defect and closure of the ventricular septal defect. And so up to now, we are on this level of an atrial arrangement. So left atrial appendage isomerism. Now, if we look at this right-sided appendage, it connects with a right ventricular type of mass, and the other appendage connects with the left, morphologic left ventricle. If we look further to see what kind of vessels come off them, you will see that this is a pulmonary trunk connected to the morphologic right ventricle, and there is pulmonary to tricuspid continuity here. On the other side, the aorta comes off the morphologic left ventricle, and there is quite a significant infundibulum, as you see, separating the arterial valve from the atrioventricular valve. This was the ventricular septal defect. So just to sum up what we have here, juxtaposed morphologic left atrial isomeres juxtaposed to the left with concordant atrioventricular connections, concordant ventricular arterial connections, but parallel arterial trunks. You can see this pulmonary trunk that is located where you would expect the aorta is located to the right and posterior. The aorta is located anterior and to the left.
But still arising in parallel fashion.
But they arise in parallel fashion. Now, in the post-mortem report, it was also mentioned polysplenia.
Right. Can I correct you on one point? Because you said concordant atrioventricular connections. In fact, they are mixed.
Oh, they are, sure, biventricular and mixed. So, of course.
But with right-handed ventricular topology.
Yeah. Yes, the right ventricle is located here. And as Diane beautifully showed us how we placed our right hand in terms of the palm on the septum, thumb on the inlet, and the other fingers to the outlet.
But it's a beautiful example there, because in the heart you're showing us now, as you say, there is no infundibulum in the morphologically right ventricle. So show us that again, the fibrous continuity.
So if I lift here, this is the pulmonary valve. This is the tricuspid valve, comes all the way up. So there is continuity between the two. I'll put my forceps just to grab the valve, and you see the forceps goes up to here.
Beautiful.
Yeah, I grab it from behind all the way.
And it's simply showing us that even though we have concordant ventricular arterial connections with parallel trunks, the infundibular morphology can vary.
Absolutely.
And so what a beautiful example. And again, with the juxtaposed appendages, as with the one that Vera showed us, but your heart has juxtaposed left appendages, whereas her heart had juxtaposed usual appendages.
Yes, indeed.
Adrian, are the appendages on this heart on the left or the right where the juxtaposition?
They are on the left. They are on the left.
I'll show it again. So let me zoom back. This is in attitudinally correct position. So right side of the patient, right lung. There is no appendage here. If I turn to the left, this is the appendage that is the guest, and this is the native appendage. Both of them left, and both of them on the left side.
So left juxtaposition of the appendages with both of the appendages being morphologically left. Beautiful example.
Now, a short one now, a small heart. This is the heart with the tricuspid atresia. So I'll have to zoom. This was a 10-day patient who had no patent arterial duct and died of after being operated for tracheoesophageal fistula. And if we look here, I'm turning just to show that this is a morphologic right atrium that is on the right, but has no other communication with the ventricular mass. It has only a communication through the atrial septal defect towards the left appendage here. So there is an absent right atrioventricular connection, whereas on the left, if I open this atrium, is morphologically left, located on the left, with connecting through a mitral valve with the dominant morphologic left ventricle. If I turn the heart back, what do we have out of these ventricles? It's here, this vessel that comes off the morphologic left ventricle is an aorta. You can probably see a little coronary there. And then from the other side, so located anterior and to the left, it's the pulmonary trunk. So I'll take away this end of the appendage, morphologic left appendage, and I'll show you how we dissected the right ventricle. just to show you how here it connects with the pulmonary trunk in parallel. So these are vessels that are in parallel. So the incomplete right ventricle is anterior and to the left in this case. Nevertheless, the connections between the ventricles and the great trunks, arterial trunks, are concordant, and the great arteries are in parallel. And if we look inside, there is aorta to mitral continuity on this side of the ventricle. So this is where the aortic leaflet ends, and this is the mitral valve here. And yes, probably the fact that there was no patent arterial duct led to the demise of this patient. But it's a great example. So again, this is attitudinally correct position. This is where the aorta is. This is where the pulmonary trunk is. The right ventricle is anterior, superior, and leftward.
Beautiful. And do you have one more to show us?
One more if there is time. Almost 4 years old here. Patient that the operation that he had was closure of the ventricular septal defect and pulmonary stenosis that was corrected. So let me orientate myself. This will be attitudinally correct position. This is the right atrium. You see the atrium that was used for surgical access. And if I open this right atrium, it's a the right ventricular morphology, right atrial morphology. In terms of the appendage, it's an intact atrial septum. You can see the oval fossa floor here. It connects with the morphologic right ventricle. But then if we look what comes off this morphologic right ventricle, it's a pulmonary trunk. This is the patch used to close the ventricular septal defect. I'll reposition the heart just to show you where the pulmonary trunk is. So the pulmonary trunk is here, where you would expect the aorta. So it's rightward, posterior. Going back to the left, this morphologic left atrium connects through a mitral valve with what is, I hope everybody agrees, the morphologic left ventricle with crisscross trabeculations. Looking at what comes off this ventricle, well, is this vessel, which is the aorta. And let's look how this vessel sits. I'm looking at the base of the heart. So it's anterior and to the leftwards to this pulmonary trunk that is here. And they are in parallel fashion. So looking at the infundibulums, the aorta, it's difficult to say now, the aorta, sorry, but there is a small sleeve of muscle between the aorta and the mitral valve here. So I would say there is a little bit of a, I'll try and show it better. It's not a lot, but I think there is a sleeve of muscle between the mitral valve and the aortic leaflet. Whereas on the other side, there is pulmonary to tricuspid fibrous continuity. This is the tricuspid, this is pulmonary leaflet, and they communicate here. So this is another example that I wanted to show in the end.
I mean, it's absolutely exquisite because you've shown us in the 5 hearts that you found for us, the ones that I said were particularly rare. You've shown us tricuspid atresia, you've shown us left isomerism, you've shown us another lovely example of double inlet ventricle, and then you've recapitulated what we saw initially in Vera's case, which is the heart you've just shown us, and you've repeated what Rohit showed us. But you've shown us the variation that we can find in infundibular morphology. And what the infundibular morphology doesn't matter because in all of the hearts we've been looking at, there are concordant ventricular arterial connections with parallel arterial trunks. And it is that feature which unifies all of these hearts and gives the clarity that I was hoping we could get out of this final session. So Adrian, that was an absolutely spectacular demonstration.
Thank you.
Very good.
Oh, we see you there. We can see Adrian now. It's working.
It is.
So you've sorted out the IT problems as well. We can see you nicely from Birmingham.
We hope so. So I think we can start discussions if there are questions.
Okay, guys, if you have questions, please type on the Q&A chat box. And I'd like to listen. So today we have 3 panelists. We have Dr. Silverman, Dr. Quintasenza, and Dr. Javier Gonzalez. So I want to listen to their inputs of all of we have seen so far, starting as usual with Norman.
Hi, I want to just share my screen for a moment, if we can do that. And I'll just show you this specimen from the UCSF archive, because we were talking about juxtaposition. This is a different case. The vessels are not spiraling, but here is an example of left juxtaposition of the atrial appendages on the right side, Bob. You asked me to show you that.
Right-sided juxtaposition of the left atrial appendage.
Correct.
Yes.
Okay. So I just wanted to...
The vessels are spiraling in this case, are they not?
Yes.
So this is not, you're showing us this just to make the point
Just
we can have a right-sided juxtaposition of the morphologically left appendages.
Correct. So, I mean, I think that I was a little confused by the title because of my previous association with this condition, some of these conditions, as basically anatomically corrected malposition. And that is
a terrible term, and we should.
I understand that. I understand that now. However, the problem is, for me, is also maybe a problem for many of the people listening to this. And I think that what this talk, particularly with all of the different specimens from different collections, has shown us that this is a rare association. I have only one case echocardiographically in my archive. But I think that what you've shown us about this is that in terms of describing the heart in a sequential segmental morphology, it is no terror to anybody. We can get that correct. And that, I think, is the important issue.
You're right, absolutely. It doesn't really matter what you call, you don't have to put a label on them. As you say, if you simply describe sequentially what is going on, it speaks for itself.
Yes, and I think maybe that's why it hasn't been the parallel outlets, which is perfectly easy to identify echocardiographically, for example, merely just simply in describing the outlet. This is another form of the ventricular arterial connection that you can just put in directly into your segmental analysis, and you have it all.
Absolutely, absolutely.
I think there is a question. Sorry, there is a question from Paolo Zielinski, and because I made the mistake, if I can answer that, the question is: in right or left atrial appendages isomeries, the mixed atrioventricular connection may still be named ambiguous. And I think the reply is no, we should avoid, because there is nothing ambiguous or confusing about the connections. Half of the heart will be concordantly connected, half of the heart will have discordant atrioventricular connections. So it's far better to use mixed atrioventricular connections because it's a mix of the concordant and discordant, but there is nothing ambiguous about it.
And I agree with that. I mean, the point that Paolo is making is that we used to call this an ambiguous connection, but we realized the mistake for all the reasons that Adrian has now explained. So
I think that's correct. I would enforce that, except that what I think maybe echocardiographically, for those people that are doing this, where you can't actually recognize the atrial morphology, you can't really make that connection that clearly. So still there will be a group of patients where you cannot recognize atrial appendage morphology echocardiographically, where you might consider that's ambiguous because you can't define it completely.
But Norman, in this day and age, you would know there was so-called visceral heterotaxy.
Absolutely.
So in that instance, you would know that you would be dealing, even if
dealing with mixed connections. I mean, we made this point last week.
And then the key point would be to determine whether there was right-handed or left-handed ventricular topology, because that's the real
easy. That's easy.
Right, Grace, who's in charge?
Yeah, okay. Dr. Quintessenza, do you want to add something to the discussion?
Is Q with us? I don't see him on
Yeah,
my...
he's there.
Hi. No, I've just enjoyed listening. Really, I think all the points that have been made very clearly. I don't really have a lot to add other than these are rare lesions. The isolated, the AV discordance, which some people call ventricular inversion. I feel like you don't like that term either, Bob.
Correct.
So actually, it's a very nice corrective, procedure, right, to do either a mustard or a sending in that, and you actually normalize the patient's, correct ventricular arterial, connections, essentially. Anyway, I think it's been very, very interesting and great presentation as normal, but don't have a lot to add. So.
Have you operated on many of these cases yourself?
Well, I think I've done 2 isolated settings. And one was juxtaposed position, atrial position, so it wound up needing a kind of a mustard because it was difficult to do a setting with juxtaposed atrial appendages. But those were very, nice outcomes for the patients. There is one thing I would add too. When you have, malposed parallel arteries, in the setting, for example, of pulmonary stenosis, or would be equivalent to maybe a tetralogy type of arrangement, it does give you some additional options in terms of transannular incisions because the coronaries are in a different position relative to the outlets, which we didn't really speak to very much, but again, these are rare things, but I think it's important to define the coronary anatomy as we're thinking of how we could correct some of these lesions with those unusual outlet arrangements.
Well, it's good to have you with us, and thank you for your comments. And we hope to do more with you when we get to next session starting in September.
We'd be happy to join. Yes.
Great.
Thank you.
And Dr. Javier Gonzalez, do you have something to add to the discussion? Welcome.
Javier, where are you?
I can see him as a panelist. I'll be unmuted. Good.
You have to unmute and share and stop and share your video.
I don't. Are you listening to me now?
We are, yes, we can hear you.
We want to see you.
No, but I don't think that I was. I don't know why you were asking me that. I was not planning to add anything. I don't know if I did something wrong. I was just listening to the great dissertation that I enjoyed a lot.
Perfect. Thank you very much.
Sorry.
Thanks, Javi.
I should tell everybody that Javier was one of the first fellows that I taught when I came over to Charleston, when I allegedly retired. Javier is now working in Tampa. He's on the other side of the queue, is in St. Petersburg. Javier is across the road in Tampa. So Javier, it's good to see you again.
That's very nice.
Good to see you too. Thank you.
Thank you.
Oh, there he is.
And Dr. Diane, do you have something to add?
No, I don't. I think the hearts that Adrian produced were awesome. I have not seen many hearts with absence of the infundibulum between the tricuspid valve and the pulmonary valve. So those were very interesting to me. And it just does prove the point that Bob has made, that infundibular morphology is one of those variable features. So very interesting presentation. I enjoyed it.
The amazing thing, I mean, Diane, you will know that we've been through the Idris archive, and I think we found what, 1 or 2 in the Idris archive?
Yes.
You've been through the Pittsburgh archive, and I think again 1 or 2 at the most. You don't have any in the Van Meerup archive.
I don't think so.
So it is amazing that in the Birmingham archive, and Adrian and I went through that together, I hadn't realized we had quite so many hearts and such a fascinating series. And as you say, with such strange infundibular morphology. So it must be something that's in the water in Birmingham.
Thank you, Diane. The one thing I need to do is to learn to do the videos as nice as you are doing them, because these hearts need to be recorded. Now, one question from Carlos Troconis: is the term great arteries malposition wrong? I think it's as useful as the term heterotaxy. It only tells us that something is not as it should be.
And there were tears of someone who thought that the people that were taking care of them knew what the hell they were doing for less than.
Very nice. We have two more questions, and from Pranav, asking, is it possible for moderator band to be present in the left ventricle? Is a moderator band a sequela of spiraling?
You can have, it's a good question. You can have strands that cross the cavity of the right ventricle, of the left ventricle rather. Many people call them telegraph wires, but they're not at all like the moderator band. The moderator band is one of the septoparietal trabeculations, and that is a feature of the morphologically right ventricle. So although you can have anomalous muscle bundles in the left ventricle, particularly in the setting of excessive trabeculation, I would not call them moderator bands. So I would say, no, the moderator band as a septoparietal trabeculation is a feature of the morphologically right ventricle.
Okay, very nice. And the last question, how would the conduction system be disposed in AV discordance with VA concordance with striding left side tricuspid valve?
Now that is a very good question. I would still anticipate in discordant atrioventricular connections, it would be an anterior node and that the conduction axis would run. And because the aorta is arising from morphologically left ventricle, I'd expect the conduction axis to run in front of the aortic root. But I say that off the top of my head. Adrian, correct me if I'm wrong, but you have a heart there, do you not, that has precisely that?
And I was looking exactly how we described in the heart that I showed you with atrioventricular discordant connection. And the mention that we made when we looked at this heart a few years ago was that conduction should start at the anterior atrioventricular node, but here it seems to be normal.
Ah.
That was the remark that we put when we described this heart.
But we now have the potential to do micro CT on the Birmingham archive, do we not? So that is something that potentially we could look at, because these are questions that now with these new techniques like micro CT, we can look for the conduction system without destroying the heart. And I know that is one of you have a potential project in hand using micro CT with the Birmingham heart. So maybe that's one of the hearts we should look at.
Exactly. We were talking about the heart that, the large heart with the outlet septum that was deviated.
Yeah.
Totally.
So at the moment, I think it's an unanswered question, but we will look into it.
Very nice. As usual, an amazing session. We are so happy to have done this one. And it was a great closure for the 1 year work.
Indeed. If I can just say, it was amazing what you put together when you introduced the session, to see so many people who've been tuning in to our Congenital Heart Academy sessions. So, and 65,000 views. And also the point you made that those webinars are now available for ongoing study. So hopefully we'll be back in September and we'll build on what we have learned this year. We'll try and incorporate everybody. And I think today with bringing everyone together was excellent. And we'll work out a program for you and watch this space, as they say.
Professor Anderson, if I may say, not even a pandemic can stop you. We have to.
Well, it's good, Adrian, that eventually we've got you on board as well, and you've sorted out your IT problems, because your presentations today were long and match those of Diane, which have been spectacular throughout the year. So thank you both.
Thank you.
Thank you very much, guys. And thanks for attending. We are going to have a break with Dr. Anderson's sessions, but see you on the other activities of Congenital Heart Academy of July.
And
Thank you.
We should also say that Norman still has one session to come. So yes. Functionally univentricular heart. And so we look forward to welcoming you back in September, Norman.
Yeah, thank you very much, Bob. I look forward to it. That's been an incredible educational experience for me and solidified my Andersonian philosophy.
Thank you for that.
Great.
Yeah.
Okay.
Bye, everyone.
See you soon.
Bye.
Bye.
Bye-bye, everybody. Have a nice vacation.
Right. Thank you.